Good afternoon, everyone. Today, I'm very happy to say that the Department of Microbiology is going to present the clinical rundown on a very important neglected topic, that is Nocardia. I would like to request Dr. Seema to come and give an introduction before we get into the article.
Thank you, Dr. Bimal. So I'll be just giving a brief introduction about Nocardia. As you all know, are ubiquitous environmental saprophytes occurring in decaying plants, soil, and aquatic habitats, including wastewater systems. They cause opportunistic infections, and an estimated 60% of the infections occur in immunocompromised individuals and 40% in immunocompetent. So, coming to the taxonomic history of Nocardia, which is actually both confusing and conflicting. The journey started in the year 1888 with Edmond Nocard, who was a French veterinary doctor and also a microbiologist, who described gram-positive filamentous branching bacteria in cattle with bovine farcy and named it as Streptothrix farcinica after the Greek word meaning twisted hair. It was a year later that Trevisan characterized it, defined the genus, and named it in honor of Edward Nocard and called the organism Nocardia farcinica. It is he who also deposited this in two separate culture collections, that is ATCC and NCTC, and they were given the designated numbers there. So in the year 1890, the first human case was reported by Eppinger from a case of brain abscess, who called it Cladothrix asteroides, which in Greek means branching hair, and asteroides because of the star-shaped colonies. And this was renamed as Nocardia asteroides. Now, thereafter, with the advent of chemotaxonomic methodologies, it was decided that Nocardia farcinica be designated as the type species of the genus Nocardia. But as more work continued and the phenotypic tests came in place, it was Ruth Gordon and his colleagues who were working on phenotypic tests who felt that Nocardia farcinica, defined by Trevisan, and Nocardia asteroides, that was defined by Eppinger, were actually the same, and that these were two different names for the same species. And he continued, the entire team continued the work further, and as work continued, there was also more confusion. And it was found, and of course, the later studies included just not the mycolic acid content, they included the GC content, the fat susceptibility, and also there was inherent confusion on the original isolate, which was obtained from Edward Nocard. There was a lot of uncertainty around it. And the fact that Nocardia asteroides and farcinica are so similar that he and his team actually made an appeal in judicial commission to rename the type species to Nocardia asteroides. So for many years, it was Nocardia asteroides that was thought to be the commonest, and it was only later it was realized that it is because of the limited battery of biochemicals that a lot of these were identified as asteroides, and on retrospective analysis, it was realized that many of these were incorrectly identified. So then came the modern era with the use of molecular methodologies, initially the RFLP, then the sequencing, and a number of new Nocardia species have been identified, and previously identified species have been regrouped. And it was also realized that the members of the Nocardia asteroides complex were actually not similar. So the term Nocardia asteroides complex was also not considered valid. So if we look at it today, there are about 100 species, 50 of which are clinically significant. Here is the scientific classification and the common species which have been reported worldwide. Coming to the transmission, common mode, inhalation. Pulmonary exposure typically occurs due to inhalation of airborne bacteria or dust particles containing the bacteria. Or transmission can also be through direct inoculation into body, which is traumatic, or through dust or dirt entering open wounds. Person to person transmission has not been reported. Animal to human transmission has not been reported. It is not a zoonotic illness. And no direct person to person transmission has been reported, although there are a few reports which talk about indirect transmission via contaminated hands or fomites. The infection is not usually hospital acquired. Some outbreaks have been reported in hospital settings, more to do with oncology unit, transplant units. And one of the outbreaks in the renal unit was actually due to the contaminated air ducts, which they could actually demonstrate. Hospital infection due to contaminated medical equipment is very rare. So if we look at nocardiosis, it can either manifest as pulmonary infection or as cutaneous infection or disseminated disease. And when it is disseminated, brain is the commonest site of infection. I should have included the head here. So the next question is nocardia a part of normal flora? Nocardia is not a part of normal flora of skin, respiratory tree, or the gastrointestinal tract. So what are the key characteristic features of nocardia? These are gram-positive, really delicate branching filaments with characteristic beading. And this is how we actually see it in clinical samples on gram stain. And this is basically a spot diagnosis. Apart from this, the other characteristics include that the cell wall contains mesodiaminopyruvic acid. Apart from that, it has arabinose and galactose. It is weakly acid fast, so it also contains mycolic acid. Although the mycolic acid is not the long chain fatty acids, it is shorter ones, typically 46 to 56 carbon atoms. It is strictly aerobic. It is slow growing, yes. Some of them may grow in 48 hours, but typically it requires more than 3 days and may take up to 2 to 3 weeks. Coming to the culture media, it will grow on a variety of media used for bacteria, for mycobacteria, for fungi. So it will grow on blood agar, it will grow on algae medium, it will grow on brain heart infusion agar, it will grow on saccharose dextrose agar. In fact, we prefer to put it in saccharose dextrose because we require a longer incubation and the tubes will be more conducive for that. And something which I have learned very late in life is that it can also grow on gonococcal culture medium. And actually, Thea-Martin medium can be used as a selective medium for isolation of nocardia. The duration of treatment for this is longer, typically requires antibiotic therapy for 6 months to a year, long duration antibiotic therapy, and more will be discussed later about it. Coming to the incidence, again, globally reports are in conflict, whether the incidence is increasing or remains stable. I was going through a CDC report and it says an estimated 500 to 1,000 cases occur annually. And this is based on the data on the strains deposited with them and also a clinical survey with the ID physicians. So when we look at other places, we have mixed. There is a study from Spain which says that the rates are more or less stable, while a study from India says that there is an increase, and we are sitting in a scenario where we know that the number of immunocompromised people have increased. We know that they are surviving longer. We also know that the other risk factors have come into place. We know the diagnostics have improved, yet there are two conflicting reports. So now I'll request Dr. Ankita, our SR, to continue.
Thank you, Dr. Simba ma'am, for the brief introduction. So I'm going to continue the discussion about the epidemiology, classification, and clinical spectrum of Nocardia. So before coming to the classification, initially Wallace and his colleagues had classified Nocardia into 6 groups of Nocardia asteroids based on the drug pattern, which was based on the antimicrobial susceptibility patterns. So they found that the Nocardia isolates can be classified into these groups. The major group being a first group, all of them were susceptible to ampicillin, carbonicillin, and broad spectrum cephalosporins. And another group being class 6, where they are resistant to penicillins but susceptible to broad spectrum cephalosporins. But following this, all the previous taxonomy classifications were based on phenotypic methods. But as of now, we are more relying on molecular techniques for accurate species determination, and 16S rRNA sequencing is considered as the gold standard. So the advantage of molecular method is that it has helped in expanding the spectrum of pathogenic nocardia. And following the molecular techniques, there had been significant taxonomic changes which has occurred, and we were able to reassign the species within different genus. So as Simama has already discussed, Nocardia asteroid species complex is not anymore used because it includes a heterogeneous group of organisms. So all the isolates within the Nocardia asteroids drug pattern group have been reassigned to different groups as shown here. So these are the most frequently isolated species, which include Nocardia farcinica, abscessus, brasiliensis, otitis discavarium, etc. So coming to the epidemiology, worldwide, the respiratory and disseminated infections are seen predominantly in immunosuppressed hosts. Nocardia brasiliensis is one of the species where which was isolated commonly in immunocompetent host, and it is known to be the commonest cause of mycetoma. And they are reported mainly from tropical regions of US, Central and South America and Australia. And we can see that the species distribution, they vary according to the geographical region. And ma'am has also discussed this point that Nocardia species is a well recognized cause of infection in animals, and the most common, they cause bovine mastitis. But as of now, there are no reported animal to human transmission. So coming to the clinical epidemiology, Nocardia georgica, Nocardia nova, and Nocardia farcinica are the species which are mostly isolated from respiratory and disseminated infection, predominantly in immunosuppressed hosts. And the common causes of pulmonary nocardiasis include Nocardia transvalensis and Nocardia otitis discavarium. And CNS infections are predominantly caused by Nocardia pseudobrasiliensis. And Nocardia brasiliensis causes cutaneous infection in immunocompetent host, mainly in tropical area. And it is also known to be the major cause for keratitis. So coming to the virulence mechanism of Nocardia, the virulence strain of Nocardia, they are facultative intracellular pathogens, and they have various mechanisms by which they can evade the immune mechanisms, which include they have an ability to neutralize the acidic pH within the phagosome, and they also inhibit the fusion of phagosome and lysosomes. Also, they have an ability to resist the toxic oxidative metabolite by, especially in case of Nocardia asteroids, they secrete a unique superoxide dismutase which will secrete large amount of catalase. So this catalase will protect the organism from oxidative killing by phagocytes. So what are the factors which will determine the disease manifestation and outcome? They include, first is portal of entry. So respiratory nocardiosis or pulmonary nocardiosis mainly through inhalational route, and the various spectrum of cutaneous nocardiosis is through inoculation route. And it was also seen in literature that Nocardia has a tissue tropism towards CNS. And as I've discussed, they have the ability to survive the phagocyte attack and evade the immune mechanism. So the protective immune responses, they are majorly T cell mediated. The outcome of infection will depend upon the ability of the strain to inhibit the neutrophil leukocyte response and also the subsequent attack by activated macrophages. And also, characteristic of infecting strain is a major factor because there are certain more virulent strains such as Nocardia farcinica, which are also very difficult to treat. So the risk factors for Nocardia, we have seen that in immunocompromised patients, particularly patients with defects in cell-mediated immunity are at higher risk. The most common risk factors include, firstly, patients with solid organ or hematopoietic stem cell transplantation, or those who have received immunosuppressive medication within 100 days of Nocardia diagnosis. So these are the other risk factors among recipients of solid organ transplants, such as cytomegalovirus disease within preceding 6 months, or high levels of calcineurin inhibitors within preceding 30 days, or use of tacrolimus. Glucocorticoid therapy is another risk factor. So patients who have received corticosteroid, which is equivalent to around 20 milligram per day of prednisolone within past 28 days, were found to be having a higher risk factor for Nocardia. And also patients having solid hematological malignancy who have received chemotherapy within the past 1 month, they are at higher risk. So pulmonary nocardiasis as such, which is a major cause, which is a major major spectrum of nocardia. The common risk factor include chronic lung diseases, and most of the patients have had an underlying structural lung defect or bronchopulmonary obstruction or bronchiectasis. So these are the common risk factors I've enlisted. So coming to the clinical spectrum, it can be either primary cutaneous nocardiosis, pulmonary, or disseminated nocardiosis. Pulmonary nocardiasis, lungs, they are the primary site of nocardial infection in more than 1/3 of the cases. And most of these pulmonary infections are primary, and from lungs they can spread to other sites, and the major site being brain. So pulmonary nocardiasis can mimic, or it can even present as an exacerbation of an underlying disease such as COPD or sarcoidosis. So this is a chest radiograph which is showing the right upper zone consolidation. So the major radiology findings in case of pulmonary nocardiosis are consolidation, cavity, abscesses, and nodule. Most of the pulmonary nocardiosis patient, they present with non-specific signs and symptoms such as cough, fever, expectoration, breathlessness, and weight loss. So there is a high index of suspicion necessary in such cases to pick up to diagnose these cases early. So approximately 20% of cases of extrapulmonary nocardiosis infection that they can occur even in absence of a pulmonary disease. So out of the 50% cases of pulmonary disease, they can disseminate, as I've said, they can disseminate to other site, and the major site being the brain. And the complications such as empyema, mediastinitis, and pericarditis can also occur in patient. So the diagnostic criteria for pulmonary nocardiosis include symptoms, as I said, non-specific signs and symptoms like fever, cough, hemoptysis, or chest pain, and a pulmonary imaging which shows infectious lesion, and isolation of nocardia from clinical specimens such as sputum, bronchoalveolar lavage, or pleural fluid. And we detect the pathogen in laboratory based on modified acid fast staining, or KH calcoflow white mount, or bacterial culture. So coming to CNS nocardiosis, the major hallmark feature in case of CNS nocardiosis is a parenchymal abscess in any region of the brain. So they will present with symptoms such as fever, headache, or signs such as meningismus. So nocardic meningitis is usually a very infrequent manifestation, and it can occur with or without a brain abscess. So in such cases, the presentation will be a subacute or chronic meningitis, and the CSF picture will be similar to that of bacterial meningitis with hypoglycemia and elevated protein concentration. So coming to disseminated nocardiosis, the definition is two non-contiguous sites of involvement which may or may not include the primary pulmonary focus, and the major sites which are involved other than pulmonary, CNS and cutaneous are bone, heart valves, joints and kidneys, and it can also involve most of the other organs, and can either present as multiple abscesses within the body like epidural abscess, retroperitoneal abscess or sinus abscess. And primary infection, it can also result from inoculation into the eye, presenting as keratitis, which is most commonly caused by Nocardia brasiliensis. So primary cutaneous nocardiasis, they can present as either superficial cellulitis or abscess, which occur due to direct inoculation of organism into the skin. And this will be clinically indistinguishable from lesions which are caused by other pathogenic bacteria such as Staphylococcus aureus or group A streptococcus. And lymphocutaneous infection, the primary nocardial skin infection later goes on to involve the lymphatics and produce nodular lymphangitis. So they will be similar to the presentation of sporothrix, and therefore it is termed as sporotrichoid nocardiasis as well. So another presentation is mycetoma, which is a chronic suppurative deforming granulomatous infection, which involves skin, subcutaneous tissue, and mainly feet. So these are the differentials which we should keep in mind in case of this clinical spectrum of nocardiosis. So in case of pulmonary nocardiosis, we should keep in mind other mycobacterial infections such as due to Mycobacterium tuberculosis or non-tuberculous mycobacteria as well. And in case of CNS nocardiosis, we should first keep in mind the brain abscess caused by other fungal infections such as Aspergillus or Cryptococcus. And similarly, in case of cutaneous nocardiosis, we should keep fungal infections as other fungal infections as our first DD, which is due to either Aspergillus or Sporothrix or Cryptococcus species. So how do we diagnose nocardia in the lab? So direct microscopy also plays a crucial role in diagnosis along with culture. In direct microscopy, gram staining, they will appear as gram-positive, beaded, thin, right-angle branching filaments, which is less than 1 micrometer in diameter. For nocardia, we perform special staining, modified Zell-Nielsen staining. They will appear as acid-fast branching filaments. And in lab, we have also seen that since the presentation of pulmonary nocardiosis is very non-specific, even though there were no clinical suspicion among such patients, since we routinely perform KOH calcifluor mount for all the pulmonary specimens, we were able to pick up branching filamentous structures which are fluorescent in the KOH calcifluor mount microscopy, which further was followed up by modified Sedden staining, and we were able to diagnose these nocardiac cases. So coming to culture, as ma'am said, we can they grow on a wide variety of media. So blood agar, they will appear as wrinkled, pale white pitting colonies, and we can also use Sabaros dextrose agar, which is a commonly used media for other fungal species. And LJ media, which we use for mycobacterial culture, can also be used for nocardia. And the selective medium we use is buffered charcoal yeast extract agar. And as I've said, genotypic detection, 16S RNA sequencing is the gold standard. So the proposed algorithm for management for isolated pulmonary cases, disseminated cases without CNS involvement and with CNS involvement. For isolated pulmonary cases, cotrimoxazole along with imipenem or amikacin or cefotaxime can be used. So if there is no CNS involvement, we can give cefotaxime in dosage of IV 2000 milligram once daily. Whereas if there is CNS involvement, we have to increase the dosage and we have to prefer cotrimoxazole with imipenem and or amikacin. So after when there is improvement in the patient, we can switch down to oral therapy with cotrimoxazole, and the duration of therapy for isolated pulmonary cases would be around 6 months, and for disseminated disease without CNS involvement is around 6 to 12 months, and for CNS involvement we can prefer around 9 to 12 months of therapy. So coming to the antimicrobial susceptibility pattern of Nocardia, we have seen that two species is found to be resistant to most of the antibiotic, Nocardia farcinica and Nocardia otitis discavarium. So I need to stress the importance of performing an antimicrobial susceptibility pattern for all of the Nocardia isolates, because these up to and identification up to the species level, because these two species, they are found to be having very high resistant pattern. So as I've said, antimicrobial susceptibility pattern testing have to be performed in all cases of nocardiosis. So I'm sharing an 8 years of experience from our laboratory. So we have performed this retrospective observational study from January 2015 to April 2023, or duration of 8 years. And we have included Nocardia which were isolated at least one culture from respiratory sample or tissue or pus sample which yielded Nocardia species. And along with it, patient had compatible signs and symptoms of infection. So we retrieved the data from the medical records, such as patient demographics, comorbid illness, and the type of immunosuppression. And along with it, microbiological investigation, majorly direct microscopy, culture, and species identification was done by 16S rRNA sequencing. So coming to the clinical epidemiological data of the nocardiosis cases, a total of 35 culture-proven nocardia cases were encountered during this period. So the mean age of patients was 34 years, and it included also one child who had presented with disseminated disease. We have also seen in literature that nocardiosis is seen more commonly in adults and comparatively lesser in pediatric population. And we saw that the male to female ratio in our study was around 3.5:1, and it is similar to other published reports from India. And the reason for this gender difference is not really known, and it can be attributed to mainly hormonal effects. So coming to the correlation between age and sex, we have seen that among all age groups, there is a higher predilection among males. And coming to the infection type, we have seen that among all age groups, the predominant site of infection is lungs, followed by disseminated disease. Coming to the risk factors, we found that out of the 35 patients, underlying risk factors were observed in 20 patients, and among that, 16 patients had immunocompromised status. And the predominant risk factor for immunosuppression was either solid organ transplantation, or one patient was PLHIV. And the major solid organ transplantation we encountered was post-renal transplantation. And other risk factors include pre-existing lung disease, and one patient had an occupational exposure. The patient was a farmer who presented with cutaneous nocardiosis. So here we have seen that nocardia infection can be seen in both immunocompetent and immunocompromised patients. And the percentage of this immunocompromise, it varies among different studies. There was a Northern Australian study which had shown that only 1/3 of the patients were immunocompromised, whereas another survey in US had shown up to 85% of the patients who had immunosuppression. So we have to keep in mind that nocardia can present in both immunocompetent as well as immunosuppressed patients. So coming to other major risk factor, organ transplantation, they are at higher risk for developing nocardiosis, and the frequency varies up to 1 to 20%. And the pre-existing lung disease, it is found to be a major risk factor in case of pulmonary nocardiosis. And in India, there were around 12 case series, out of which 7 of them had shown that patients had an underlying bronchopulmonary disease. So as I've said, the clinical features, they are majorly non-specific. Patients have presented, most of the pulmonary nocardiosis have presented with fever, weight loss, shortness of breath, and cough with expectoration. So high index of clinical suspicion is necessary to pick up these cases early. So coming to the major sites involved in our cases, the most common site was lungs, which contributed around 74%, followed by disseminated infection around 14%. So in our series, there were one patient who had involvement of both brain and lungs, patient involving both lungs and abdomen, and one patient who had multi-organ involvement. So we have also seen in literature that the commonest the commonest site of infection is mainly CNS, followed by disseminated infection, which is reported around 17 to 23% of the patients. And as I've said, the radiological findings major being consolidation followed by cavity and abscess in lung, and CNS mainly present with brain, CNS nocardiosis present with brain abscess. So coming to the microbiological diagnosis, direct microscopy was positive in about 60% of the patients in our case series. So all modalities of direct microscopy have to be carefully observed in order to facilitate the early diagnosis. And as I've said, we have incidentally picked up many cases of pulmonary nocardiosis and KH calcoplo white stain as well, because we routinely perform this. And in culture, they appear as dry wrinkled pitching colonies. So following this, for identification, we have performed both Malgitov mass spectrometry and 16S rRNA sequencing. And Malgitov was able to identify around 6 species correctly, but 2 species was wrongly identified by Malti, Nocardia asiatica as Bajangensis and Nocardia levis as Farsinica. So these are the most common species encountered in our case series. The most common being Nocardia serracegeorgica, followed by Nocardia bajangensis. So for performing antimicrobial susceptibility of the isolates, we have tested using sensititer, and CLSI has recommended broth microdilution as a technical reference standard for Nocardia, and these are the breakpoints. So this is the antimicrobial susceptibility pattern of the isolates we have tested. We found 100% susceptibility in both linezolid and amikacin, and quadramaxazole and imipenem has shown 90% susceptibility, and ciprofloxacin had a higher resistance rate, only 30% were susceptible. Following this, we compared the antimicrobial susceptibility pattern using broth microdilution and disc diffusion. This table shows the categorical agreement. So we have the disagreement is shown as very major error, and minor error. So very major error is any isolate which is resistant, which is being reported as susceptible, and major error is susceptible isolate reported as resistant, and minor error is any intermediate isolate which is reported as either susceptible or resistant or vice versa. So we found that out of the 70 drug work combination which we have, there were 14 categorical disagreements, but overall the categorical agreement rate was 80%. So we can say that disc diffusion is a reliable method for amikacin, linezolid, and quadramoxazole, and unreliability with these drugs such as ciprofloxacin and augmentin. So the treatment given for patients in our case series were imipenem with or without ciprofloxacin and amikacin, and the all-cause mortality was found to be 25%. So as I've said, nocardia cases can be seen in both immunocompetent as well as immunocompromised patients, and the most frequent species were Nocardia serracegeorgica, Bajangensis, Otitis discavarium, and Asiatica. And as I've said, Nocardia identification up to the species level is important, because there are certain species which are relatively resistant to antibiotics, such as Nocardia farsinica and Otitis discavarium. In a study, we found that this diffusion can serve as an acceptable method for most of the first-line drugs which we use for treatment. Thereby, it can enable us in early diagnosis and treatment.
Thank you, Anita and Dr. Seema, for the elaborate presentation. Now, actually, we wanted to discuss nocardiosis because it's rarely actually discussed in CVR That's why. So stage is open for the questions.
Thanks. So, thanks for the presentation. First thing that I noticed was that the AIIMS perhaps cannot get cases over 8. It's not shown the something in the data where it's seen possibly for it's not. Because Nocardia patients, they have an incidence onset and primary Nocardia, they might mimic some of the patients of tuberculosis.
Yeah.
Is there we are missing out on these patients? We are sending samples. We are sending it right now. They try to apply relief from us. Second, I want to ask you about the initiation. Last time we had one patient disseminated mucosis. This patient was not done. These xenopactin and Volvico, this is they happen in vaccines.
I'll answer. Because most of the sample actually we get in microbiology lab or the nocardiasis cases. And sample, you said that maybe from clinician, actually, if they are suspecting, they should write it in the form at least so that it's easier for us to actually process. Anyway, we process all the bile sample actually, maybe we centrifuge it and we see in KOH calcofluor. But if you are really suspecting, then you should write it so that we make for all sample that modified ZN also, because somehow we have seen that it's like maybe in one sample you may not get, because we put only one drop. So maybe we'll have to see multiple. So that way, so we will make like gram stain we see for all, KH also we see for all. So modified ZL maybe we can do for all the samples, all the respiratory samples. And speciation routinely we actually do conventional method, not in the molecular method, because molecular again. You will have to do the sequencing, we send it outside. So that's why. That if we have 4 or 5 together, then we do it, not routinely.
That speciation will affect the management.
Most common species what we see that is not resistant. 2 of them are more resistant. So what we commonly get that is not resistant that much. So it will not affect that much.
So, in a routine, if it is not done, that is.
And sensitivity we do it for all the, so that way we can inform.
Why can mismatch? What can be the possibility between MALDI and sequencing them?
Actually, we don't have database in Maldi, maybe because of that. And for Nocardia, they have a separate kit for the extraction also. Maldi, they have a separate extraction kit. So that also they have for 50 isolates, and it's very costly. So that also we don't get it, because you have to finish. If you have 50 isolates, then only you can. That's why. Okay, if there is no questions, then maybe we can stop it. So thank you everyone for listening.